Good morning, good afternoon, or evening to everyone joining us, and welcome to this ASPPH Presents, a webinar on global public health diplomacy, opportunities for effective practice and collaboration. My name is Rodrigo Reis. I will serve as moderator for this session. This webinar makes the use of Zoom Q&A function. Please feel free to submit any questions. You have opportunity throughout the webinar to click and put your questions on the bottom of your screen and typing into the pop-up box. We will hold on addressing any questions until we reach the Q&A portion of this session. As I said, my name is Rodrigo Reis. I'm a professor and assistant vice provost at the Washington University in St. Louis, and I'll be serving them as moderator for this session. We will hear from these speakers today. First, we have Dr. Matthew Brown from the Global Health Policy and Data Institute at the University of California, San Diego. From San Diego, we move to Midwest. We will then hear from Dr. Ashish Joshi, Dean and Distinguished University Professor at the University of Memphis, the School of Public Health. And from the Midwest in the US, we go all the way to Europe. Finally, we'll have Catherine Kane, Technical Officer in the Health Workforce Department with the WHO. Without further ado, we move to Dr. Brown.
Sorry, was unmuted there. Thank you very much. My name is Matthew Brown. I'm going to talk to you about the tradecraft of global health diplomacy. And I'm thrilled to be able to participate in today's ASPPH global seminar on opportunities for effective practice and collaboration. A few disclosures. This presentation contains my own views, and they're not the position of the US government, US Department of State, or the Bureau of Global Health Security and Diplomacy, where I work. This is really based on my own personal experience serving as a health diplomat abroad. I've served over 11 years in China under multiple tours. H1N1 and COVID were bookmarks of that time. Ethiopia, I've served with PEPFAR for over 20 years. Cote d'Ivoire, doing HIV vaccine trials. PEPFAR, I opened the CDC office in Haiti and worked in the late 90s in Kazakhstan around TB dots. I've served the majority of my career with federal agencies working abroad. A lot of this work is done from my PhD concluded over a decade ago from UCSD. I put my dissertation title there if you're really looking to put yourself to sleep and you're really interested in health diplomacy. But I've focused majority of my career on this topic of advancing the science, practice, and tradecraft of global health diplomacy, and I'll explain that in a few moments. I'm actually based out of Washington, D.C., having returned to the United States after more than 20 years abroad. Serving in the State Department, but I have an academic affiliation with the Global Health Policy Institute and the University of California at San Diego. I'm going to talk a little bit about diplomacy and the effective practice and collaboration, really highlighting the current topics and particularly the workforce aspects of how we prepare for future pandemics by strengthening our workforce. I'm going to share 3 relevant publications that I've published over a decade ago and desperately need more academic attention, especially in the post-COVID world where we're living. And I'll end with a call to action. So first, some definitions. What is global health diplomacy? 20 years ago, you didn't really hear the terms global health and diplomacy in the same sentence. Now we have conferences, journals, significant public health resources. The framework is fairly simple, but the field really needs more development. Improving health improves relations among nations. Oh, I'm seeing myself here. There we go. Improving health really improves relations among nations. I shared some of the early publications which use the term public health diplomacy, and you'll hear a little bit more of an evolution of that term, global public health diplomacy. So the problem is health diplomacy is really an emerging field. It links global health and foreign affairs. Global health, the definition I'm using is taken from Jeff Copeland, the former director of the CDC, where he really posits the terms of global health as an evolution of the term international health, where we looked at establishing borders to be able to contain diseases to keep our population safe, whereas the concept of more porous borders and economically linked countries really necessitates a different understanding of global health and involves the advancement of social equity and other aspects of multiple nations needing to work together to control diseases as they cross borders. And then foreign affairs. Foreign affairs is really the art of advancing the needs of the state through persuasion and attraction, through diplomacy. These are different fields and they have different independent priorities. And there's really no standard framework, terminology, or defined competencies. So without that, how do we measure? How do we monitor? How do we recruit for a field and train a workforce without a shared standard of practice, without some standard accreditation? And the impact of this really leads to confusion when defining complex global health actions, aligning the appropriate actors, tools, and expectations. So my first publication was published back in 2014 when I was working in the Office of Global Affairs at HHS, which supports the health attachés abroad. And the issue was that there was no definition of a health attaché published. So we pulled together a team of health attachés, including myself, and published the first tradecraft model of health diplomacy. Really, the tradecraft is the skills and knowledge applied in service of a trade. And we presented this pyramid of health diplomacy. I included the link because it's a little bit dated. It was published out of AAAS in Science and Diplomacy. But the pyramid of health diplomacy is really a framework to be able to characterize global health action. And at the core of health diplomacy is core health diplomacy. This is really state-to-state action. And the tools that core health diplomacy draws on are treaties, agreements between governments. And the actors are health attachés, diplomats. They represent one state to another state. When I'm serving abroad as a diplomat, I have an accreditation. My visa comes from the government and presenting my credentials to a foreign government, and they accept those credentials. That's a very formal process and necessitates kind of a different types of application when we're talking about health diplomacy. Multi-stakeholder diplomacy is really state. It could be state to state, but also state and non-state action. And this is really partnerships across agencies and institutions. And we have a representative from WHO. So this is a perfect example of multi-stakeholder diplomacy in this panel, but really government agencies and multilateral institutions, their representatives when they engage is different than when a state to state engages. And I would posit that that's still different than informal health diplomacy. And this is really public health actors and their counterparts. I work with PEPFAR, the President's Emergency Plan for AIDS Relief, the largest public health initiative in history. And it has an army of public health actors that are engaging and crossing borders and talking to government counterparts. That really is a type of health diplomacy, but it's different than multi-stakeholder, and it's different than state to state and core. And the tools are different. They're agreements, funding agencies, humanitarian agencies. And these actors are also representatives of non-government. They could be private enterprise. They could be a government employee or university. So we put this framework out there to really characterize the different actors and the tools, and to make sure that we're aligning our various definitions. But why is it a pyramid? Because it becomes more accredited and formal as and the number of actors are very few. You only have one ambassador in the United States that represents the United States government to a foreign government. And the same thing goes with the other diplomats in the embassy or health attachés. There's only 7 abroad. And then as you go down the pyramid, you have greater number of practitioners, and the specificity around their accreditation is a little bit different. So if you talk about recruitment and defining competencies, I think it's important to characterize it in such a way. And again, this paper really focused on health attachés and diplomats, but in order to have global health action, you need all levels of the pyramid. And it's really incumbent upon us as practitioners to really align our research or our training to these various actors. The second one was part of my dissertation work, and I published it after I had done the study and did the dissertation work. But it's really the first time to look at global health and foreign affairs competencies. These two fields need to intersect, and they have training for foreign affairs professionals, diplomats, and global health professionals. And there's several competency models that are out there. So we wanted to explore that, and we did that in this paper. And again, you can take a look at it. So really, one step first is what is a competency? And then we're using this in a very academic term, but it really is the knowledge that you gain through mentored, through didactic learning. So if you read about an appendix and the anatomy of where the appendix is located, that would constitute knowledge of the appendix. And if you operate on a cadaver and remove the appendix from the thoracic cavity, you will get very good at that surgical technique. But if a patient comes in and has a headache and you take out their appendix, that wouldn't be an appropriate knowledge, applied skill in the context that would make sense. So it's really a behavior that's essential for the performance of an individual or a group. And it's the appropriate application of that knowledge and skill at the appropriate time. So why is it important that we define the knowledge, skills, and core competencies? It's to standardize approaches across the institutions, help recruit staff with the appropriate skills and knowledge, and then define mastery levels across a career. So we pulled competency models. World Health Organization has one on global public health. ASPPH published a global public health competency model that I used in this research. CDC had a competency model that is published through FETP for their global health workforce. FDA has one for their regulatory. Department of State has foreign affairs competency model, and we're one of the only countries that really publishes our competency model, and it defines how diplomats are accredited, but then progress through their career. So this was done in 2016. I pulled the models in 2015, and really no one has looked at this since. But we had this really interesting intersection. So if you actually are interested in the pedagogy of pulling and comparing competency models, happy to talk to you more. But these are the results we found. So global public health, when you hold these models and you create an aggregate, they overlap in some places, and they are discordant in other places. They diverge substantially. So where they diverge is substantial knowledge. So global public health people do not have sufficient knowledge or training in foreign policy objectives, strategies, program organizational governance structures that diplomats get a lot of. Same thing in leadership. Global public health really doesn't have a lot at this time of didactic practical, how to lead a team, how to work effectively across large organizations, across bureaucracies, how to be a catalyst for change and anticipate future problems. Those are the more advanced leadership skills that you get if you are going through diplomat school in the US government. And foreign language skills, you don't really have to achieve a functional level. The US government diplomatic corps has competency level models built into their accreditation process to get tenured. So you definitely need solid language skills, but you don't necessarily need that in global health. So foreign affairs, they're also lacking in public health communication skills that we get as public health professionals. We, as a public health professional, understand how to target a population, develop and measure effective messages, and monitor that message for effectiveness. We don't in diplomat school, in the Foreign Service Institute, get a lot of public health skills. How do you prioritize various disease prevention and control actions? How do you allocate public sector resources toward disease control? And we definitely saw ambassadors and missions without public health skills or staff inside their mission to help them accommodate this, asking questions about, well, China's giving away a vaccine. Is that good? Is that bad? Where do we want to allocate our US resources in this foreign country? Public health professionals can address that, but not necessarily unless you've been trained. And then interpersonal and ethical knowledge around culture, around political and policy differences is a type of training that you receive as a public health professional. How do you interpret research around population ethics? How do you apply them to health? That's not something that foreign affairs professionals get. So the last publication is something that I wrote in 2022, is ranked by the Council on Foreign Relations as a top paper for 2022. It got quite a bit of attention, but I was sitting in the embassy in Beijing through the pandemic and really saw a failure of US health agencies to be able to meet the needs of the COVID pandemic at the right time, at the right place, with the right skills. We actually closed the FDA office at a time that was the most critical for the US government, right in the very early days of the pandemic, because we didn't have a robust workforce. We actually have a diplomatic workforce for development, which is USAID, for plants, animals, and agriculture, which is Foreign Agricultural Service, or the Animal Plant Health Inspection Service. We have one for commerce to be able to promote US businesses abroad. We have one for radio, the Voice of America. We have one, of course, for diplomacy, which houses the embassies and the ambassador corps, but we don't have one for health. And really needing those competencies for health as well as in diplomacy, I think is a critical shortcoming. And I make my argument in this paper. So here's my call to action. There's over 100,000 members of the Association of Public Health Programs and Schools. And really, this is the voice of academic public health. We need more partnerships to tackle these questions. How do we create stronger public health workforces, be able to facilitate more effective global health action when the world needs it the most? I think there's many areas where I think we failed as public health professionals and we failed as diplomats. And we need more competency model research, training, developed, tested, refined. So I'm thankful to ASPPH and the organizers of this workshop and my fellow panelists to ensure that we can work together and really prepare for the next pandemic. It's coming, and I hope we can be more effective in responding to it when it comes. So thank you for participation, your attention. Thanks to Rebecca for organizing this, and to my esteemed panelists, and I'm really eager to listen to their publications as well. Thank you very much. I'll stop sharing and turn it back to you, Rodrigo.
Thank you, Dr. Brown. Thank you so much. Very, very exciting to hear this presentation. Without further ado, Dr. Joshi.
Yes, thank you so much, Dr. Rodrigo, and thank you so much, Dr. Brown, for your very insightful groundworking. Actually, to be honest, we were very impressed by the work what you've been doing since, and your call to action was listened. So I hope that this presentation highlights a little bit of the work we're trying to build together. And I just want to thank ASPPH for actually organizing this webinar at such an important time of our uh, focus of where we are right now. So I just wanted to a little bit highlight about the role of public health diplomacy in the 21st century. Uh, I'm Ashish Joshi. I'm a Dean and Distinguished University Professor with the University of Memphis School of Public Health. What really intrigued my interest is my background of being a clinician in public health and then informatics, cross-cutting work across 14, 15 countries. And I think that diverse experience reflected that it's not only about doing and just conducting research in international countries, it's also very important aspect to understand how to do consensus building, how to do negotiation, and how to reflect those findings into practice, and where do we really lie. So this is one effort towards that. Uh, so without further ado today, I'll move, just building upon what Dr. Brown mentioned, that health is a very important contributor to the development, peace, and poverty reduction, social justice, and human rights aspect of the thing. So to be very honest, as Dr. Tedros said, you can't be healthy if you don't have peace. And so health is a very important element for that. And we just need to make sure that there are other factors that are attributing to improving the health. Just for the sake of our audience, like defining diplomacy is a critical component, and we call this more like an art and practice of conducting negotiations. So it's kind of to be honest, we might be using diplomacy in all our day-to-day work, but we may not define it as such. It is an instrument by which states they implement their foreign policy and articulate and defend their national interests. However, as based on the earlier presentation, it does not capture the broader role of other non-governmental organizations and other non-state actors. Because diplomacy is not just acting traditionally through the state-to-state relationship. There are other actors now that play a very, very important role. These could be funding agencies, private organizations, non-governmental organizations also. Where do we see the intersection between health and foreign policy? Obviously, there are several things, but some of the three key areas where we saw is emerging infectious diseases. There's a kind of a health during the issue of conflict and post-conflict reconstruction, and also the health response to the natural disasters. These are the three broad areas where at least a very clear-cut intersection can be seen between health and foreign policy. However, foreign policies can also hinder or support health. It's not always going to be supportive to improving health. There are certain decisions that might be taken that might also impact the progress of making it towards a healthy call. So I think there is a need for strengthening partnerships across various ministries, not just from the Ministry of Health, but also Foreign Affairs, the Trade, National Security, and other things. As Dr. Brown earlier mentioned, it was very interesting from us, like when we were going through the literature, obviously there were 5 tracks of foreign services, and I'm not going to go through each, but I just want to say that health did not exist. And that was really surprising, that individuals who are coming from the foreign affairs and the foreign services trying to make decisions on the health and not having the people from the health background at the table. So I think that was a kind of a gap that was kind of identified. Uh, just building on, and as I said to you on the earlier presentation, that yes, core public health diplomacy can be done in a very formal way, but where does public health diplomacy lies? It lies between the intersection of informal and multi-stakeholder. That's where the public health diplomacy comes in. That means we need to have public health diplomatic advocates that could actually engage the informal and the multi-stakeholder engagement that could actually further bring in the core public global health diplomats together. So it's kind of a convergence of the different players and what that convergence should look like. So in our view, it was looking like that this public health diplomacy could be an important area that needs to be expanded. Why public health diplomacy is needed right now, to be honest. I know we talk about local and global, but there is a lot of accelerated globalization of public health happening. And globalization is leading to what is needed is anything which is global is also local today. So we have to have a local context to the global interconnectedness. Numerous global threats, the countries and their representatives, they do not normally interact only through diplomatic channels. We've seen that now post-COVID, during COVID. There is a need for commitment to global cooperation, global governance. And then how do we really communicate this messaging to different audiences, to different stakeholders in a way that kind of is more relatable and not really thinking from the lens of just top-down approach. So it's very important to have influence that should come across various sectors, but also cross institutional and cross sectors. The 4 C's that are in public health diplomacy that could be useful is in collaboration, coordination, cooperation, communication. But I try to add the 5th C, which is called compassion, because compassion is going to be an important component. And how do we really, they work with each other is not in overall sustaining development, improving health programs, improving data-driven, evidence-based decision-making, and to achieve fair and equitable health outcomes. That's the ultimate goal, that we need to have a fair and equitable health outcomes. We do need I know that the traditional diplomats, they require help. We do need to have a specific workforce which is trained to know how to negotiate, how to understand the agreements that can address global health in a collective manner. There are a growing number of countries that are now engaged in health policy. Values of integrating health into all government policy is recognized. So there is a lot of actually, if you look at different summits and conferences, as Dr. Brown earlier mentioned, are having now diplomacy as a critical component of their track. There has to be an intersection or interface between diplomatic and public health forums that need to be there. We need to identify new knowledge, skills, and abilities. And lastly, but not the least, is there needs to be a cross-cultural training, management and negotiations training for health professionals from a multinational perspective. To address some of these challenges and opportunities, the School of Public Health at the University of Memphis, in collaboration with the Association of Schools and Programs of Public Health and the Global Network of Academic Public Health, was able to establish Public Health Diplomacy Lab at the University of Memphis. To the best of our ability, this is an effort to really bring the intersection of international relations, global health, and policy to train the public health workforce that could actually have the better understanding of how to engage the stakeholders, consensus building, negotiations, and outcomes. This is the kind of a framework what we are looking here, how to bring people from the different sectors. For example, international intellectual technology transfer was a very big challenge, actually, as a diplomatic effort during COVID-19. Where the vaccines go, trade, and how does it impact trade and related policy? What is the role of regulatory frameworks into that? What are the management aspects of that? So we had on September 25th to 27th, with all our esteemed colleagues who are on the panel, with their collective wisdom, we were able to organize our Public Health Diplomacy Summit. It was represented by about 15 countries, about 31 experts. I'm very delighted to share that some of the topics of discussion, I think this whole work is the deliberation and an effort of the representation of all the different public health associations around the world. These were the 4 key questions that we were looking for. And based on Dr. Brown's, your work and call to action, we try to frame the things which were here and the work what WHO has been doing in preparing the public health global workforce. Just to cover the last slide is about what are some of the initial findings we found from these discussions. Where could interface happen between the health and the diplomatic space? One was on health diplomacy in the conflict zones, understanding about cultural sensitivity and inclusivity, enhancing visibility and advocacy. We did found that engagement with communities is a very important element. It's not just nation to nation, but it's also the local collaborators, the local stakeholders, which can play a very important voice. Data security and ownership in international collaborations was another. One second. As earlier mentioned, communications, interpersonal relationships came out to be extremely significant. And I think communication is now more critical, especially when we are dealing with issues like misinformation, mistrust. So how do we really prepare the workforce to train the public health professionals in this direction? Enhancing public health diplomacy education and building infrastructure. What are some of the global and regional collaborations which are needed? I think we need to have a cross-institutional, cross-sector, multinational, multidimensional collaboration for these platforms. I can say we were able to find a definition that was kind of presented by all. It's a multidisciplinary field that should enable practitioners to effectively communicate, facilitate, negotiate, and build consensus using strategies like systems thinking, evidence-based and community-informed approaches, and equity focus on human-centered values. It was very intentional to ensure that we have a broad representation of the stakeholders input into that. This is an action plan that was supported by participants of what we need to do call for action. And I think this is a call to action to Dr. Brown's your statement of what we are planning to do, that how do we create a space and a venue where we can actually bring these stakeholders together in a way that we can address the gaps and can move the needle forward. And lastly, this cannot be possible with all the, I know we started the summit with Together We Can. By the time we reached Together We Are. And by the time we concluded, we said Together We Will. So I just want to acknowledge each one of the panelists and those who are not on this panel, who have given their valuable time, insights to us to really make this as a comprehensive effort and a way forward. So thank you all. Thank you for the opportunity. And thank you, Dr. Brown. And thank you, Catherine, for such valuable insight of what you've contributed. And Dr. Rodrigo, even though you are moderating, it will go without saying your participation and valuable insights. So Dr. Magania is not here and my other colleagues. I just want to thank everyone for taking this opportunity to bring this to this platform for us to talk about it.
Thank you so much, Ashish. Very exciting to hear about the findings from the workshop. And I'll pass the word to the fantastic Catherine Kane, who will be presenting now.
Well, that's my kind of introduction. My name is Catherine Kane. I am a technical officer with the World Health Organization. I'd like to point out clearly, however, I am not representing the views of the organization within this discussion, presenting some perspectives based on my personal experience as the staff member of an international organization accredited as a diplomat with what we call laissez-passer, my favorite little blue passport. I have had a similar diplomatic status in Geneva, Switzerland, when I was involved with an international organization, the International Federation of Red Cross and Red Crescent Societies, and not a diplomatic passport, but a unique diplomatic experience as a member of a national auxiliary to public authorities in the humanitarian field. And I've also done professional graduate studies in contemporary diplomacy. As long as we're advertising things that nobody should read, I'd like to introduce you to Humanitarian Public Diplomacy, International Calls to Action in the Digital Era, which is now obsolete because the past 5 years have changed a great deal. But if you're looking to waste some time, read my dissertation. Okay, so with that, let me go into our topic of the day. And I'm going to draw actually a couple of elements from some of my recent studies in diplomacy, in public diplomacy. And as my colleagues have already presented, diplomacy started out as one man saying, I'm going to send a man to another government, and he's going to travel many days, and then he's going to tell the other government what we think and try to get what we want out of it. Now, you can see in the cartoon, which is an illustration from the Diplo Foundation, that once diplomat was characterized, an ambassador characterized as an honest gentleman sent to lie abroad for the good of his country. Now, it's interesting to think about what we consider that now, and as we look at the evolution of diplomacy. So particularly in the 20th century, we had some really dramatic evolutions in the way that we thought about diplomats, and that had to do with a number of different factors. One of them is the engagement of a broader set of actors, and that includes the United Nations, which, as you will know, is a 20th century invention, started as the League of Nations, became the United Nations. We have international organizations that have been formed over the years, many of which are focused in specific issue areas. We have non-governmental organizations who operate in the international space and operate very heavily in national and regional spaces. We have new actors like, for example, in our space, the public health diplomacy, we have new actors like the African Union, Africa Centers for Disease Control and Prevention. Now, that's quite interesting because they are specifically looking at health and they're looking to guide regional capacity. And that is a new actor with whom we are interacting. We have development banks that are investing. Now, traditionally, governments might have given what they call development aid to another country, and the goal of that was to get the other country to do what they wanted to, whether it's raising your hand in the UN General Assembly and saying, I support, name the country that's being persecuted, or I support, name the country that another country thinks is persecuting them. So got a lot of really interesting elements happening with the new actors in the space. We've got expanded areas of work. Now, you can't really say that health is new. Health is kind of a constant. When we have living beings, we have health. But the greater focus on it is something that we're certainly seeing expanded through the 21st century. We've got areas of work like cyber coordination. We've got exploration of space. We've got new ways of looking and new requirements to work together. And a lot of that has to do with the way society is evolving. We've got travel is much easier. I'm not riding a horse for 5 days to get from Paris to Geneva. I'm calling. When I'm dealing with member states now, as I've been doing for the past couple of weeks as we draft resolutions for the 78th World Health Assembly, some of them are joining from Capital in the Philippines in Manila at night. Some are sitting with me in Geneva. Some are sitting in their homes in Geneva. Some are waking up at the crack of dawn in Washington or San Francisco to join these discussions. So we've got a lot more capability to talk with each other, and we've got different target audiences and delivery methods. We're on Zoom right now. 5 years ago, you'd have a webinar and it was a really big thing. Now, if somebody doesn't know how to mute and unmute themselves, well, you have to admit that somebody's going to do it in a webinar, but you hope it isn't you. We've got the public and particularly as we look at public health diplomacy, they're a stakeholder. And they're not only a national stakeholder or a local stakeholder or a health facility stakeholder, they're an international stakeholder. We've got leaders, we've got the use of social networks. So diplomacy is changing in a number of its different facets. And I think this is something that we can all explore together because we might not agree. So who's the actor that I'm most familiar with? Well, here's our Constitution. The WHO Constitution is set out in, as you see, the document that was presented in 1948, drafted in 1946. And what are we trying to do there? We are, by nature, excuse me, it's conducted by and through the United Nations for better health security and population health, improved relations between states, and a commitment of a wide range of actors. I've heard PEPFAR also mentioned today, to work together to improve health. And lastly, achieving outcomes deemed fair and supporting the goals of reducing poverty and increasing equity. So it's important to understand too that, as my boss is often fond of saying, health is a team sport. So health isn't health. Health is jobs. Health is economics. Health is equity. Health is, in and of itself, a driver for peace. So when you have these things, and certainly trade actually also pulls into this, when you have all of that, you have more peaceful societies because people can get their basic needs met. we can look at Maslow and how we're adjusting the hierarchy. But what have we got here? WHO established in 1948, multilateral body. Are we in charge of all the health? Well, that's interesting. We guide through expertise, but I'd also point out that we are, in fact, the servants of member states. They guide our work and direct and ask the Director General to do things, and that is through the diplomatic meetings that are known as the Executive Board and the World Health Assembly, which happen every year. This you can see towards the right side, all of the nice typing that I did, talking about how public health diplomacy has been conducted in the international space through the international sanitary conferences, the establishment of what's now known as PAHO, which is part of WHO and also part of itself. The first Geneva Convention was in 1864. Then we have the Geneva Conventions and their additional protocols from 1949. We have the 1946 International Health Conference that in fact spawned the World Health Organization, your World Health Organization. Please feel free to wish me a happy 75th birthday and tell me how young I look. So this uses diplomatic tradecraft to achieve the objectives that require international cooperation, that defy national boundaries. We've got a perfect example right now, and young people will never understand how we tried to explain H1N1, H5N9. It sounds like Dr. Brown and I spent a lot of time in some pretty similar spaces over the past couple decades. But it includes all these new actors. It brings in increasing elements of public health diplomacy. So you can look at the portfolio that Dr. Joshi very nicely described with economic, political, trade, security, public affairs tracks. They were the ones that I was desperate to get into. I wanted to work for my country. I wanted to be a diplomat. Now, did I end up doing that? I ended up going a different way, and it's a way that works really well for me. And I'd say this is one that I'd also want to present to students when they're thinking about what they want to do in public health diplomacy. So negotiating policy, it requires a lot of the elements that have been discussed here. And it's the drivers of health: science, economics, equity, data and statistics. Data and statistics are huge. We have greater capacity to analyze. We've got more people analyzing, more people creating their own data, more people creating their own facts. And it's really important that we look at how we influence those who are presenting and how we're engaging the public itself. And that is one of the particular elements that is within the study of public diplomacy itself. And what channels are you using? What do you want the public to do? As I said, I did something on international calls to action. Ooh, I've got a heck of a lot more that I could look at right now beyond the MDGs. But we need to look at how we are influencing, and we need to think about the people who are doing that. So do you want your policy officer in your State Department, in your Ministry of State? Do you want them fully representing? Do you want them to be able to reach to health specialists? Do you want them to be working together? Do you need a specific public health diplomatic corps? It's something that I think that we need to explore, something that we need to develop together and look at what's the model that's going to make the most sense. Now, as I said, I work within the WHO, and if you look at any of our resolutions, you're often going to see according to national context, in alignment with national policies, strategies, and objectives. So you'll see a lot of language in there. Are we going to be able to define something that works for everybody within our goals to create a public health diplomacy corps? Let's be realistic about it and understand what works for whom and where. So just dropping some of those in. Now, what's needed? I'm actually pulling some slides. So we've been doing this at WHO. We had a training for our WHO country offices in 2015 that looked at the end of the Millennium Development Goals era, the development of the SDGs, and it started looking at, do they need the skills? Do we need to be teaching those skills to our country officers who, and our country representatives, our leaders, who traditionally are actually doctors? Are they public health doctors? Are they surgeons? Traditionally, we got doctors, which is great. Do they have the skills they need to be able to work with the government to convince, to talk to the public to convince? Traditionally, that's public affairs officers, and they're going there to, for example, if I look at the country that I come from, The public affairs officers I know were meant to go to countries and bring in jazz bands and tell them how great the US is and try to make all of the people in country Z want to be Americans because we're so cool and we're better. So we've got some interesting ways of thinking about how we're training the officers overall. But we've got formal education that combines public health and diplomacy, tradecraft. That's, I think, a really smart objective. Equipped with the knowledge, skills, and behaviors, the learning outcomes for data, dialogue, and decision-making. And quite frankly, in my field, we also say data, dialogue, decision-making, and dollars, because all of us need to support the work that we do. And where are these people? They're actually within not just the Ministry of Foreign Affairs, but also in some of the other agencies. We do a lot of work with the Centers for Disease Control and Prevention in the US, in the UK, in the Africa CDC, in Asia. A lot of those actors also need these skills. So let's be ambitious about where we're looking. And then within the UN, international organizations, civil society, academia, boy, do we need that. And I'm really excited to be talking to ASPPH about this, because you're not only the drivers, you're the folks who want to have these skill sets and as influencers. So let me just zip quickly, because I think because I'm so enthusiastic about this wonderful field of work, I've overdone my time. You be doing convening discussions around the development of the curricula, looking at the learning outcomes. Now, I'd like to build on what Dr. Brown was talking about with regard to competencies and the relationship with developing knowledge, skills, attitudes, and behaviors. So what are the learning outcomes that are needed to meet these public health needs? I'd encourage people to take a look at some of this. This is drawn from the Global Competency and Outcomes Framework for Universal Health Coverage. And then we're looking at establishing curricula based on the health system needs and competencies and outcomes required. And that is part of something that actually ASPPH is a partner in, which is the National Workforce Capacity for Essential Public Health Functions Roadmap. And that is looking at what are the essential public health functions to be delivered? What are the competencies of the workforce who's delivering those? And who are those workforce? It's not just public health. It's not field epidemiologists. Golly, that's a hard one to say. It's sanitation officers, it's police understanding what their role is. It's actually leaders understanding what their role is. So join us in that, because we've done a lot of thinking about how to develop those skills. Follows the approach that's widely accepted by the health professions education community, inclusive of entrustable professional activities. And the learning outcomes include all of these KSA from pre-service learning, from practice activities, the tasks that are being done as defined in employment literature and ISCO standards, the International Standard Classification of Occupations, often what you see in a job ad, for example, or a description of what is a public health officer, or what is a diplomat, and the competencies, which are demonstrated through the behaviors and progressively developed. So I can become more competent, I can gain more knowledge, but having knowledge of how to perform, as Dr. Brown well said, I can know how a surgical intervention is performed, but without being mentored in doing that and developing the competencies to do all of that, I don't think you want my knowledgeable self to jump into somebody's heart. And the same thing is true of diplomacy. So here's a starting point. And in fact, we have this within our global competency and outcomes framework for the essential public health functions. Brand new document, link in here, happy to put it in the chat. We identify that policy authorities, political authorities need these skills, and they need to be able to convey this to political leaders. I think we saw very clearly in the emergency phase of the COVID-19 pandemic, that leaders aren't necessarily aligned with science and health. And we need to be able to convince them. We need to be able to drive those conversations and be trusted participants in these conversations. And it's not just for emergencies, it's for every day. We look at well-developed countries and we have horrific things like one country last week banned midwives from practice because they're women. So they're delivering babies from women. That's by nature. Those are the only ones the babies come out of. Working with women and babies, and yet they can't work because they're women. So do we need public health diplomacy to work with that government to safeguard the lives of their people? Yeah, we do. We've got other countries where vaccinations are going down. It's one of the most amazing things of the 20th century. Vaccinations, saving lives with a little pinprick. Good heavens, people, how on earth can we do without public health diplomats, even internally, to show the benefits of taking these steps to protect our health and livelihood? So those are the starting points. That's the end of what I've got to say. I've got a lot more to say, but I'd rather really hear from you and talk to your questions.
Thank you, Catherine. I could also be listening to you for another hour. It was fantastic. Thank you, Matthew and Ashish as well. So we had a question here, but if folks, and Matthew already answered, if folks now watching us have any questions, please use your Q&A button and post the questions there. Diplomacy has been part of the humankind in a way, from Genghis Khan to the League of Nations to United Nations and post-Cold War times. Diplomats were always there, building alliances, making treaties and agreements, and advancing the nation's purposes and goals. And you showed a few examples of failures, like we lack resources, we lack competencies, we lack public health specialists in certain conditions. So you all talked about that. Do we have any examples of successes where having public health trained folks or trained workforce helped advancing treaties, agendas, or conversations? That's a provocative question. So just for the audience to know, we did not prepare the Q&A, so I'm putting all the speakers on spot here on purpose. But it's an open question. Yeah, Catherine. Yeah, Catherine.
Oh, please, Catherine, you go.
Yeah, Catherine first.
I just spoke, Matt. Why don't you go ahead, and I've got a great one to follow up.
No, I was just going to share the Framework Convention on Tobacco Control. That was a very science-based. It was really our first public health treaty that really focused on a clear public health danger of tobacco. And this was raised in the question and answer, but we really don't have teeth in that convention, right? The way that trade agreements do, where we have carrots and penalties for compliance, so that, public health doesn't work. We don't really have that yet. But anyway, that's an example, I think, of a successful public health treaty. And the Framework Convention on Tobacco Control is probably the first, but there's others. Yeah, please, over to you, Catherine.
Way to take the really good one. Yeah, that framework treaty is one of the ones about which we're most proud. So I would draw in probably two examples, and both of them are actually drawing. One of them is a national example. So let me talk to you about a public health diplomat that probably will be familiar with some of the people in the room, and an actual. Now, it wasn't an educational tract, it was a training, but it actually talked to the skills that were needed. In 2009, we had H1N1, and we were thinking, this is coming. It's really big in Asia. I was working with an organization that is an auxiliary to the US government at the time. And what we did was brought together public health experts and the media. So already we're getting into the media, and it wasn't even what it is now. It wasn't the influencers, wasn't social networks. It was just traditional media, news announcers, you name it. And we said, what if we got the scientists, the public health experts, the scientists together with the media, and they can ask each other questions, and they can know what the other is going to ask and where they're going to deep dive. They can get to know each other before we have to get these messages out. You want to know who one of the people was? Got two of them, and you've actually seen them recently. One was Tom Frieden. The other one was our a man that I hold very dear and I wish my country did as well, which is Dr. Fauci. That's a public health diplomat. He told the truth. He relied on science. He gave data. He gave evidence-based recommendations. It's somebody that we listened to for an awfully long time. So that was a specific opportunity where we applied training and concepts and helped to build the competencies for two elements of public health diplomacy to talk together. The other one that I'm going to bring up is slightly unusual because the Framework Convention is more of one of those traditional ones. HIV. Got a multilateral agency. We've got PEPFAR actually, which is, a State Department, but it also drew upon the advocacy communities and the change that we've made in the fight against AIDS and HIV over the past 2 decades. It's absolutely amazing. Now we're worried right now about falling back. And I was actually talking the other day with somebody on World AIDS Day about this. But look at how far we came from where we looked at with AIDS when the outbreak started to where it became an international movement, where we have UNAIDS, where we have UNITAID, where we have the Global Fund to fight HIV, TB, and malaria. So we have the opportunity through civil society and through multilateral organizations and through governments to together create movements for health based on data, based on compelling arguments with leadership. Those are two.
Thank you so much. It's great to show great examples of successes as well. Dr. Josh, I'm not going to let you be quiet. I have a question for you here. So how are issues such as health equity, social justice, and decolonizing public health weighed in approaches to health diplomacy? I know those are topics that are dear to your heart, so that's why I'm asking you. Yeah, you're muted, Dr. Joshi.
We're switching. I'll just say very quickly, I think building on what Catherine and Dr. Brown mentioned, actually, that's a very important component. So I think one of the things which at least I'm going to give you from my lived experience, if possible. The lived experience says that we don't need to be telling people on what we need to do. I think that's the world where we are in. That's the world we are in. I think so. Having a cultural, contextual relevance, understanding of equitable, fair access outcomes is a very strong element where public health comes in. And sometimes when happen, and I think I would love to have Dr. Brown's comment on this, is when we think about like a foreign diplomat, it's kind of like, okay, that's what we need and that's what we're going to do. But when you bring the element of health into that, I think there's an element of cultural and contextual relevance. There's an element of social justice. There's an element of health equity. There's an element of disparities. There's an element of that. I think that needs to be at the table to see how negotiations and consensus happen. One thing I will have to say, which is also very, very important, we have not talked, is about intellectual and technology transfer. That's a very important element of public health diplomacy. I think if you really look at the failures, they're largely driven based on interest and priorities. And I think as public health diplomacy advocates, which I say, public health diplomacy advocates, what they could bring is that social justice lens and lens of health equity on the table to reflect that it is much bigger than what we are talking here about just transactional relation, but more on a relation that is very much integrated. So to me, I think this is something I can share only from my lived experience. I know there's one last thing I will say. There was a 2001 example of the World Treaty Organization that adopted the Doha Declaration on Trade, on IPRs and public health. That was the first declaration on IPR and public health. So I think that we need to put the public health diplomacy on the social justice and health equity lens. I think, and what Catherine mentioned very dear is data, dialogue, and obviously the dollars that are investments which we will survive. That's how I see this. That's a critical component.
Thank you so much. We are at the top of the time. This has been a lively conversation. It's an important topic. It's quite exciting to see this new initiative. Please do remember that this webinar has been recorded, and the recording will be available on the ASPPH website very soon. Also, stay tuned to what ASPPH is doing on leading this conversation. There will be more resources available at some point. I hope you all have a lovely moment whenever you are and that time you are in the globe. Thank you so much.
Thank you for having us. Thank you so much.
Thank you very much. Really appreciate the opportunity.
Thanks.
Thank you, ASPPH, and my charming co-panelists, and of course, Rodrigo.
Thank you.
Muito obrigado.
De nada. Bye-bye.
Bye-bye.
Thank you, everybody. Bye-bye.